Hello, and welcome to Measuring What Matters, using data to evaluate, develop, and improve programs. This training is the first part of a three-part data training series presented by IRIS, Innovations in Recovery Through Infrastructure Support. The target audience for our training series is any agency or program administrator who wants to learn more about how to collect and utilize data more efficiently and effectively. So the overarching objectives for this three-part series are to decide what you want to know from your evaluation, to evaluate the data you already collect and decide if you need more data, make sure that what you are measuring is what matters to your evaluation and your program, and then how do you access and organize data? How do you make sense of what the data that you have is telling you? And how do you present that data for external audiences? These first three objectives we're going to cover here in part one. Objectives 4, 5, and 6 we're going to cover in part 2. And then in part 3, we're going to do a live training working through some real-world examples. The facilitators for our training series are me, Nicole Mattocks, who's a member of the IRIS team and a faculty member at the University of Maryland School of Social Work, and Dr. Unick, who is also at the University of Maryland, and you're going to hear from in just a moment. We're also going to be featuring a community partner, Behavioral Health Leadership Institute, who's going to be talking through some examples from their agency.
Hi, my name is Unick, and thank you, Nicole, for introducing this topic. I'm also at the School of Social Work, and a lot of what we do is ask questions for research purposes. And so we have lots of questions that we as a community that treat opiate use disorder or substance use disorders we might want to know. So for example, a question we might have is, do peer navigators in emergency departments increase the number of people who start medication treatments for opiate use disorder like buprenorphine or methadone? Or maybe we run a harm reduction program and we want to know, do our harm reduction services improve health outcomes for folks that use opiates? We might facilitate self-help groups. And so we might want to know, do these self-help groups increase the time that individuals abstain from substances? Or we might have something more basic that we want to know. We want to know if we stay open longer, or maybe if we open on weekends, will individuals stay in treatment longer? There's a whole host of questions we might have where we want to know, does the thing we're doing have the outcomes that we want to do? And this training is going to be about how we figure that out. The key message that we're going to have in this training is you're going to want to think through things systematically. And there's lots of ways to do these things. There's lots of paths up the mountain. And what particular path you choose is going to depend on a whole bunch of specific circumstances that you have. But in terms of a general framework and thinking about this sort of at the 10,000 foot level, what we want to be is systematic about the way we design our interventions, design our evaluations, and gather evidence. And that systematic piece is what is represented by this lovely little circle here. One key element of this is that piece at the top, engaging stakeholders. And one thing we're going to want to do at every step of this process is ask as many people, are we doing the right thing? Are we asking the right questions? Are we gathering the right data? Are we measuring things correctly? These are all pieces of what we're going to talk about today. But these should really not be done in a vacuum. They should be done talking to all of the relevant stakeholders. That might be clinicians, that might be administrators, that might be funders, and almost certainly that will involve clients or consumers of your service. And at every step, you want to make sure you engage those stakeholders and ask them, am I asking the right questions? Am I measuring the right things? You also want to be systematic in describing what you think you're doing. And we're going to show a lot of examples from a thing called a logic model, and we'll walk through what that means. But it's really a tool that we have to describe the pieces of what we're doing. And then we're going to take that logic model and use that to design an evaluation, gather credible evidence, and then justify our conclusions using that evidence. And then we're going to share those lessons again with our stakeholders. And now we're back at the beginning, engaging with stakeholders. And that's why we have a nice little circle there. This process is going to help us figure out whether what we're doing is correct, whether it's useful. Is it feasible to do it? Are we going to collect data are we going to be able to collect the data? Is it going to be done accurately? And are we going to be able to use this to improve or understand whether the services that we're doing are improving the quality or the effectiveness or the outcomes that we really care about? These processes are, this process that we're talking about in terms of evaluation can seem overwhelming. And it's something that is hard to think about if you are thinking about all of it at once. And so something that we're going to talk about in detail is how you break this big problem into smaller problems. And then we're going to work on solving each of the issues for each of these smaller problems. And then we're going to link the pieces back together. And so at any point in the process where you're trying to figure out, what we're doing is what we're doing working? Is my program effective? The key step, the step number one, is break it into smaller pieces. And that's going to help us think through things in a manageable way. It's going to help us identify each of the issues that we might encounter along the way. It's going to help us think through what we want to measure, and it's going to help us think through the outcomes. And then at the end, we're going to loop that back together and put it together in a coherent whole. As I mentioned earlier, the framework we're going to use is called a logic model. And it's a simple idea. It's a roadmap. It's going to help us identify what resources we're bringing to bear, what activities we're doing, what outputs we're going to expect, and what outcomes and impacts of the project you have. So each of these are the pieces that we're going to break this larger project into. But behind this logic model is the idea that we have some theory of change. We think our programs do something. And the logic model helps us spell out what things are doing what things and what's the consequence of that. So it's going to help us distinguish between what we're doing and what changes we think are going to happen. Now, again, this is a complicated issue. We have PhD programs that teach people how to do this, and we're not doing that here. We're gonna think through this in a much more concrete kind of way. But where we want to start is ironically at the end. We want to think through very clearly what the end looks like, and then we're going to work backwards from the beginning to the end. And then the logic model represents a map of how we get to that end. And that end is often, we want to reduce deaths from overdoses. We want to increase the amount of time people are in treatment. We want to have people come back for more services. Whatever it is that the goal of the project is, we want to have a very clear idea of what that is. And then we're going to move from the things that we have, the inputs, all the way back to those outputs. And so let's walk through each of the pieces of this logic model: the inputs, the activities, the outputs, the short-term and intermediate outcomes, and the long-term outcomes that we might call impacts. So when I say inputs, I simply mean the resources that you bring or the things you add to make change happen. Maybe you got some new money to start a new program. That would be an input. Maybe you hired staff, or you reallocated staff time to some project. Those are your inputs. So anything that you're bringing in terms of resources, money, or persons, you want to document those very clearly. What is it that we're bringing to this process? Then we have constraints and barriers. Anybody that's worked in this field knows that things aren't smooth. Everything is difficult. And so you want to think through, what are the constraints and barriers, and what problems do you think you'll have? And then you want to think through how those inputs can address those constraints and barriers. So now you have all of the pieces that you need, and you've thought through and you've documented them. Well, what do those inputs get you? And those are your activities. What do you do with those resources to make change happen? And maybe that's serve more people or hire more people, or you're doing something with those inputs to achieve some set of outputs. Maybe it's more prescriptions. Maybe it's a whole host of things. And then those activities will get you something. What did those activities do? Did it increase the number of consumers that use your service? Did it increase the length of time that they are in service? So these are sort of the things that the activities directly bring you. And then we have the outcomes. What is it that those activities or outputs, did they have the desired effect? Did they give you what you want? Did you reduce overdoses? Did you increase the length of time people are on treatment? And then the outcomes and impacts are sort of the same kind of thing, but they differ in sort of time frame. There's shorter term outcomes, and then there's longer term outcomes. We improve the health of our community would be a larger term impact. Or we served a lot more people. We were able to reduce the number of people that use substances or reduce the number of people that had overdoses. So these outcomes and impacts tell us whether the activities and the outputs had the desired short-term or long-term impacts. So each of these pieces of your logic model should be specified. And we'll talk about a concrete example in a bit and make these abstract concepts a little bit more concrete. But before we do that, I want to just go back to this idea that throughout all of this, we are engaged in a process, and none of these are separate from the others. They're all linked together. So if we think through everything that we've talked about so far, here's sort of a map of what we want to do. We want to define the project goals. What is our research question? What do we want to know? What do we think our project is doing? We then specify the inputs and barriers. We want to think very clearly through what do we have to address the issues that are the goals of the project, and what barriers might we encounter? And then we specify action and outputs. What are we going to do, and what are we going to see as a result of that? We're going to make sure we've clearly targeted these actions and outputs to a specific group. We have some population that we want to serve, and we want to think through that. As I said in the beginning, we want to pre-test everything. We want to make sure that we're engaging stakeholders at every step. We want to make sure that every decision we've made about actions and outputs and targeting the identified group involves engaging stakeholders across the board. It's very hard to do any of these things in isolation. None of us have a 360-degree view of the problem, and that's why we go out and we talk to people. We then are going to measure those outcomes and the impact, and we'll talk a bit about what we're going to do with that. And then we reevaluate those actions, and that brings us back to the beginning, right? So this is a loop where we define a project, we define our inputs and barriers, we specify action and outputs, we identify target groups, we pre-test everything along the way, engaging stakeholders regularly. We make sure we're measuring the things that we want to measure, and then we're going to reevaluate all of the things we did.
So thank you, Jay. Now I'm going to walk through an example of a program that is active right now. This is a behavioral health urgent care clinic that has just been launched with Arundel Lodge in Anne Arundel County. So I'm currently working with this project. I'm working on the evaluation team. So what you see here is a logic model. There are many different versions of logic models out there. The one that I'm using here was downloaded from the University or the state of South Carolina Department of Education. This is a logic model that they've made available that's fillable. So if anybody is watching this video and thinks, oh, I need to develop my own logic model, then there are lots of different options out there. They should all have these section headings, though, of inputs, outputs, and outcomes or impact. And this one you can fill in. So in the rectangles here, I have gone through and filled in these sections for this behavioral health urgent care clinic as an example. So the inputs that were invested in making this urgent care clinic work were funding from SAMHSA and staff effort. So all of the different staff members that are involved in making this urgent care clinic run smoothly, the space at Anne Arundel Medical Center, and all of the equipment. All of these things are necessary to make the urgent care clinic operate on a regular basis. So some of the outputs, and this logic model kind of breaks down outputs into activities and participation. So what are some of the activities that are involved in this urgent care clinic? So it provides crisis response and stabilization services to individuals experiencing behavioral health crises. Part of the activities for providing these services are to conduct risk assessments and screenings, administer medications if there are medications necessary, facilitating any needed prescription refills, checking health vitals, and then referring out for services and other follow-up visits back to the urgent care if necessary. But a lot of what these staff are doing is stabilizing the client in the moment of crisis, and then referring out for services to make sure that they're connected to services and programs that they need. And all of this data is entered into the EHR. So these are, you know, some of this sounds like very minute, but it's really helpful to map out all of the different activities that are involved in making your program run. So we're reaching individuals experiencing crisis related to mental health, substance abuse, or overall well-being, and other providers are going to be really critical to this program, because a lot of what we're trying to do with the urgent care clinic is, like I said, refer people out for other services. So looking at the outcomes and impact, this is what really has implications for your program evaluation. And really, these are the pieces that are going to help you think through what it is that you want to measure, which is going to be the next part of this presentation here. So what the short-term results are. So you're thinking through, what are we expecting within, you know, a week, a day or a week of service receipt, something like that. So we are hoping that people coming into the urgent care clinic are going to be stabilized after experiencing whatever their crisis is. We are providing immediate services and whatever treatment they need, and we're referring them to providers. So we are hoping that in the short term, they're stabilized and that they're getting other services as needed that the urgent care clinic might not be able to provide. So medium-term results, we're giving individuals and providers an option for addressing a crisis. So that's kind of, you know, beyond just this individual's immediate needs, but thinking kind of on a slightly broader scale. We are giving the community an option for receiving crisis response services. We're also diverting crises from emergency departments. So that is one of the important outcomes for this project. One of the important goals for this project is ED diversion. So we want more people coming to receive urgent care, receiving behavioral health services at the behavioral health urgent care than through the emergency department, for a lot of obvious reasons. And we're developing a more integrated system of care through this referral system that starts at the urgent care clinic. And then the longer term outcomes, which Jay referred to before as kind of our impact, just the down the road impact that we're hoping for, is that this program is reducing psychiatric hospitalizations. It's reducing emergency department visits for anything that's behavioral health related. And we're increasing long-term stability for individuals with mental health or substance abuse. So if you can see here with these, with the longer term impacts, I'm thinking both at the individual level, the individual's long-term impacts, and we're also thinking kind of at the community or systems level and those long-term impacts that we're hoping to see. So if we were to take the example that I just walked through and think about how we're going to measure those longer term impacts for your own program evaluation, you'd want to think about, okay, how are we measuring whether or not we've been able to do that, whether or not we've been able to achieve those longer term outcomes. So how would we measure whether or not we've reduced psychiatric hospitalizations? Well, we might look at rates of psychiatric hospitalizations among people who received the urgent care services. We could also look at kind of broader psychiatric hospitalizations in the area. So looking more kind of at an aggregate level. So we could look both at people who've received services through the urgent care and people who have not. So how do we know if we've reduced emergency department visits? Well, we look at number of clients served at the urgent care clinic for one thing. So same kind of thing. We're looking at who's been served. We're looking at rates of emergency department visits among people who've been served. We also want to know the reason for the visit. So of course, sometimes people are going to the emergency department for like physical health crises, and that's what we want. We don't necessarily want to reduce people's use of the emergency department for things that are appropriate for an emergency department. So we want to make sure that if we're measuring if we're looking at rates of emergency department visits, we're also looking at the reasons for those visits. And are they behavioral health related or are they not? Lastly, if we want to increase long-term stability for individuals who are experiencing behavioral health challenges, then we want to measure clients, people who've used the urgent care clinic. We want to measure their mental health symptoms over time, if that's what they came in for, is maybe a mental illness. We want to measure their substance use over time, if that's what they came in for. Maybe other things that are related to mental health and substance use. So measuring their housing stability, measuring their overall functioning. All of these things are related to whether or not they've been stabilized through the use of this urgent care clinic. And we also want to look at their service use. And what I mean by that is services outside of the urgent care. Are they using the services that they need? Did the urgent care successfully connect them to other treatment programs and things that they might need and weren't using before they came into the urgent care clinic? So what you'll want to ask yourself as an administrator is, what data do you have? What information are you already collecting from your clients? Because a lot of the time, agencies actually have a lot of useful data to answer questions about outcomes and impact, and they just may not realize that they have so much valuable data. So you may already be measuring clinical or treatment outcomes. You probably have some data on diagnoses. You might have information on symptoms. You might be measuring depression with an instrument like the Beck Depression Inventory or the CESD. There's lots of depression measures out there. So you might be measuring symptoms already and measuring symptom change. You probably have some information about demographics, that's really valuable information when understanding the bigger picture, because demographic factors are really important to consider when we're looking at whether or not the program is effective, and who it's helping and who it's not helping. You might also be measuring patient satisfaction, maybe through kind of a brief customer satisfaction survey for people when they're sitting in the waiting room or something like that, or at the end of their time in the agency. You might also be measuring attendance if you have a program where people are coming in once a week, a day program or something where people are coming in once a week, and you have measures of whether or not they're attending. And if you have program completion numbers, which, and all of those things, all of that data is really valuable.
So my name is Courtney Nordick, and I am a PhD candidate at the Johns Hopkins Bloomberg School of Public Health, and I'm a research associate at the Behavioral Health Leadership Institute. BHLI is a nonprofit organization that's based in Baltimore City, and our mission is to identify gaps in service delivery for behavioral health and substance use services for vulnerable populations in Baltimore. One of our projects currently is the Project Connections at Reentry, or PCARE, which is a treatment van that sits outside of the Baltimore City Detention Center and provides low-threshold buprenorphine treatment to vulnerable populations. So the Project Connections at Reentry, or PCARE van, at its very basic level, we are delivering buprenorphine treatment to vulnerable populations. And so what we started out wanting to know is how many people are we reaching, how many people are being started on bup, and how many people are returning for those visits. And we're collecting outcomes and qualitative outcomes related to their treatment as they are progressing throughout the program. And one of the things we started to notice is that some people would drop out of treatment fairly early, wouldn't come back for a second visit. And we thought about how we could build upon that to address that problem. And so we developed an outreach team that could help with engagement with our patients and try to address any barriers that they might be facing to get them back and continued into care. And so with our outreach team, we had to think about a new evaluative process for how we could track the services that outreach is providing. And so with an outreach team, they're not thinking about the data, they're not thinking about collecting the data, they are just having these very human interactions with our patients on the van. And so we've gone back and forth about how we can track what outreach is doing. And so this includes just very basically who they're seeing, what proportion of our patients they're seeing, what types of services our patients are interested in receiving, and if we can actually deliver those services. And over time, we've tried to think about new ways to expand that evaluation. So is outreach successful in meeting with these people? Are they delivering the types of services that people are requesting? Are there continued barriers that people are experiencing that outreach themselves cannot actually address? And those are the types of issues that we've been trying to evaluate with our own data. So currently, as a part of our program evaluation, we collect regular data on clinical assessments, meaning the visits that our patients have with our nurses and doctors and what occurs during those visits. So we record information about the dates that people come and when they're scheduled to come back. So that in 2 weeks and 3 weeks, things like that. What we weren't collecting was kind of more information about what happens when someone misses an appointment. And so what we are doing now is to create a field or a form that's designated specifically to missed appointments. And that fields and that form will collect data such as the date of the missed appointment so that we can look at when the person last visited our program, the date that they missed it, when they were scheduled to come back, and whether or not they ever came back for another visit, how much time had elapsed between that visit, or if they never came back. So we're trying to build out our data structure, which is in a long format now because people have multiple visits with our providers, and trying to incorporate more information and data about those missing visits so that we can connect when they're attending our program and when at what point they're missing their visits, so that we can figure out, does someone miss one appointment and stop coming back, or do they miss a couple of visits and come back when they are available? Trying to identify those gaps and the barriers that people are experiencing.
Ask yourself, what data is it that you still need? So how do you define and measure success or improvement? In your agency, in the programs that your agency provides, you need to think about how you measure whether somebody has had success. Is success or improvement attendance? Is it participation? Is it satisfaction with the program? Or is it something more like treatment effectiveness? Are you expecting to see behavior change in attitude, changes in symptoms, or changes in other types of consequences like overdose, hospitalization, arrest, or criminal justice involvement, things like that. So first, you've looked at what data do you already collect, thinking about what data you need. And I just want to take a couple minutes to talk about the difference between measuring outputs and outcomes, because sometimes all you really want to measure are outputs. Sometimes all you want to measure is whether or not people are attending the program, whether or not people are using your services. Sometimes you want to measure whether or not they've completed the program, and whether or not people are satisfied with your program. But often, to really demonstrate that a program is effective in these longer term outcomes, we want to measure things like change in attitude, change in their behavior, change in symptoms, and those consequences. And so these other measures of outputs, attendance, participation, completion, and satisfaction are valuable measures, but they may fall short in terms of demonstrating kind of that longer term effect that you would hope to see from a lot of the programs that serve our clients.
Thank you, Nicole. As Nicole mentioned, we have various levels of measurement that we generally have as part of an organization, or we might want to have as part of an evaluation. And often what we want to know is, do the outputs, the things that we do programmatically, serve more people, serve a different population, provide a different kind of service? Do those outputs produce some kind of change, behavior change? So maybe people use less substances, or maybe they use substances in a way that's less dangerous, or maybe certain people don't use substances, or right. So we want to create some effect And what we're asking here is what we in the scientific community call a causal question. We're asking, does X cause Y? So how do you know whether X is causing Y? So first of all, you have to know what happens to folks that don't receive your service in order to answer that question. And in the scientific literature, the best way to do that is what we call a randomized controlled trial. But for a whole bunch of reasons, that's just not practical or feasible for most agencies and most situations. Randomized controlled trials involve a lot of additional resources, and it involves finding a large population of people, and it's just not something that we can do in most of our program evaluations. If it is something you can do, that's great. You should do it. But because we mostly can't do it, we have to find alternative strategies to ask that basic question of what happens to folks that aren't receiving your service. Because when you ask, does the behavioral health clinic, does the urgent care clinic, does that reduce emergency room hospitalizations? Well, compared to what, right? Like lots of stuff happens. We all have lived through this fantastic pandemic. And one of the things that happened as a result of the pandemic is that people stopped going to the emergency room because they were afraid of getting COVID. So if you happen to start your program at the same time that COVID started, there's a reduction in hospitalization, there's a reduction in emergency room visits for behavioral health services. So fewer people went to the emergency room because of behavioral health concerns. But is that because of COVID or is that because of your program? And you can't know that without knowing what happened to people that didn't receive your service. So if the goal is to collect data on people not receiving your services, and you can't do the sort of standardized randomized controlled trial or some of these other things, how do you do that? Well, there are a few strategies we would recommend. First of all, you might have a wait list. You might have people that did an intake but haven't received a service yet. So you can ask questions at the intake that help you understand whether when they show up for the service, did something change for them? How did they do in that time in between starting or contacting you initially and receiving your service? So wait lists or other ways in which you've had contact with people, but they haven't received your service yet, that might be one way of doing it. Another way is to follow up with individuals that didn't come back for services, or people that had some contact, but were sort of lost to service. Could you ask them questions? So finding a population of people that maybe didn't come back for your services and do a follow-up phone call. That's another way of finding out whether people that didn't receive your services, what happened to them. Or you can use other data sources. And so I think probably for most places, for most agencies, finding other ways that people collect similar data or that's collected by government agencies or by local agencies or by other agencies, and using those data sources, and we'll talk about those later, those are a good way of asking what would have happened if people didn't come to your service. So what is it? So the idea here is you have people that receive your service and you know what happens to them, but what would have happened to them if they didn't receive your service? And you want to think through a strategy for collecting some of that data. So community data or contact you've had with people, either in the form of a wait list or in the form of people that didn't come back to services. Those are all areas that you can leverage in order to find out what would have happened to people if they didn't come to your service. So you have these ideas for a variety of different things you're doing. You have examined your inputs, you've examined your outputs, you've examined your outcomes, and you have a very clear idea of what it is that you think is going to change and how that's going to work. And you've thought through some questions about how to ask what happens to people if they don't come in. So you're sort of now in this place where you're ready to begin measuring the constructs. Nicole gave a lot of very concrete examples. And earlier on, when she was talking about this example of the behavioral health urgent care clinic, she specified we have this idea of we want to reduce the number of people going to the emergency room. Well, how do you do that? How do you know whether you reduce the number of people going to the emergency room? Well, you count the number of people that came to your clinic that then went to the emergency room, right? So you're actually counting something. That is an operationalization of a construct. So the construct that you want to measure is reduced hospitalizations or reduced emergency room visits. Well, how you do that? Well, you count the number of people. Or maybe you have some outcome like depression that you want to measure. So how do you know whether you decrease depression? Well, you ask a survey instrument like the CESD, and you say, okay, so here's what people came in as in terms of their CESD score. How did they score when they finished the services? That is an operationalization of depression. So the concepts being examined in any research question have to be operationalized or measured in order to be studied. So you have the concept, and then you have to find some specific way of doing it. Saying you want to reduce depression is great, but then you have to decide how you are measuring depression. So to measure it, you have to have some idea of what it is. You have to have a very clear concept of the concepts, right? So when we operationalize our concepts, we turn them into something that's a variable. And so you're taking an idea and you're turning it into a number. Sometimes we count things, the number of hospitalizations. Sometimes we use a scale or a survey instrument like the CESD. Those turn concepts like hospitalization into number of hospitalized events or depression into a score on CESD. And that's the process of operationalization. So how we choose to operationally define a variable has a huge influence on our research findings. When we think through the various different kinds of operationalizations, we want to think through nominal definitions and operational definitions. So a nominal definition is hospitalizations. We want to reduce emergency rooms. So we're naming the thing. That's the nominal piece. Hospitalizations is what we want. Or depression. We have some idea of what depression is. Those are the nominal definitions. The operational definition is the taking of that concept, that nominal definition, and turning it into a specific thing. A thing that is, in most cases, going to end up being a number. So, for example, depression is a serious medical illness that negatively affects feelings and thoughts and actions and loss of interest in activities, right? So that's the definition of depression. But that's not going to help us for our research project until we get to the operational definition, which is an individual scoring 14 or higher on the Beck's depression inventory. Those individuals will be considered suffering from depression. Scores 14 to 19 indicate mild depression. Scores of 20 to 28 indicate moderate depression. Scores of 20 to 63 indicate severe depression. So we've moved from our idea of depression into a very concrete set of numbers. When we think through measurement, there are two basic concepts that we want to have in our head. The first is reliability, and the second is validity. Reliability is the extent to which the thing we're using to measure, the Beck's depression inventory or count of hospitalizations, will result in the same answer if we keep asking it a bunch of times, right? Are we measuring something? Are we consistent in our measurement? So if our measurement varies widely between different times we ask or different people we ask, it's not going to be that useful. It has to measure a thing, the thing that we are interested, it has to measure a single thing. So the items that we use to measure something, for example, in the Beck's depression inventory or in the CESD, they need to all measure depression, right? They can't measure depression and anxiety. They have to measure depression. If we ask the question a bunch of times, will we get the same results? So if I ask you the question, how many times did you go to the hospital in the last week? You probably are going to be able to remember that the second time I ask you that. So if I ask you again, how many times did you go to the hospital in the last week? You probably will answer the same way you did the first time, right? That's reliability. Or maybe you're going to have somebody do the evaluation or make an assessment of somebody. Do two researchers or two clinicians come up with the same answer? If you have people go through a screening for depression and a clinician then diagnoses the person as having depression or not having depression, and that's the operationalization of depression you're going to use, that a clinician diagnosed somebody with depression, do your clinicians diagnose the same person the same way? That's reliability. Validity is the extent to which the thing we're measuring measures the concept that we're supposed to measure. So when we're measuring depression, are we really measuring depression? Or are we measuring anxiety? Or are we measuring grief? We want to make sure that when we measure depression, are we really measuring depression? Do our trauma screenings actually measure trauma? Does our child behavioral checklist measure externalizing aggression in youth? Are these things capturing the thing we want? So reliability is, are we measuring something consistently? Validity is, are we measuring something that we want to measure? And there's an image, I think, that really helps us sort of get the idea. If we think about our measurement as shooting an arrow as a target, something that is reliable and valid is hitting the target regularly. Now, maybe we have something that's reliable. We are measuring something, but it's not valid. We're not measuring the thing we want to measure. Maybe we give somebody a long list of things to read, and what we're really measuring is reading ability. And so when we think through our measures, we want to make sure that we're really targeted on the thing itself. Are our questions simple and easy to understand, or are we measuring reading ability or English speaking? Are we measuring those kinds of things? That might be a reliable measure, but it wouldn't be valid because that's not what we care about. If our instruments are neither reliable nor valid, they're all over the place, they're not telling us anything about anything, and we want to avoid those, obviously. So the goal here is to hit the target. We want to consistently measure a thing. Now, how do you know this? There are a bunch of ways to do this. Research classes can teach you a bunch of that. But I think one thing that we've highlighted here that can really help us do that is pilot testing and stakeholder engagement. Ask the people that you want to know something about, does this make sense? You then want to ask people, is this the thing that we're interested in, right? And those are going to tap us into these concepts of reliability and validity. So when we talk about engaging stakeholders and pilot testing things, what we really want you to do is get to a place where the measures you're using are being measured reliably, and you're measuring the thing you're measuring a thing, and valid. You're measuring the thing you want to measure. Sometimes we can collect the data ourselves. Sometimes we have existing data sources, and Nicole has mentioned a bunch that they're using for their project, or your agency almost certainly collects some data about some things, and so you have a bunch of data. You might need to add some data collection. Maybe you need to ask an outcome measure that you're interested in, or maybe you need to do some follow-up with people, or you need to change your intake procedures, right? So those are data that you collect yourself. But that's not the only data out there. One of the great things about the modern world is that there is data all over the place that's easily accessible, that can help you answer questions about the kinds of people that you serve. So for example, you might be interested in data that comes from, that tells you something about the amount of overdoses in your community. Well, the CDC has a bunch of data on overdoses. Or you might be interested in whether your population that you serve is very similar to the demographics of your area. Are you finding the right people? The census contains a ton of data about that. Maybe you're interested in something that is like the number of liquor stores available, or maybe you're interested in transportation issues. The state has a ton of data on who receives services or what the environment looks like. The same thing with local data. I have a website here for Baltimore City, which contains a bunch of data on a whole host of things that Baltimore collects data on. So if you have a question about, am I serving the right people? You can find out, well, what does your community look like? Are you getting the kinds of people in your community that are having overdoses? Or the kinds of people in your community that are receiving treatment for opiate use disorder in the hospitals? Are you finding the right people? That's the kind of data you can get from population data. There's also a whole bunch of health data that's available. So for example, there's national hospital and medical service data from groups like AHRQ, which is a federal agency that collects this kind of data. You can go to their website and you can plop in a diagnosis and find out how many people went to a hospital in your state for that, or how many people went to an emergency room in your state. And so a lot of that data is readily available and can be accessed through websites like the AHRQ website. There's also state data on hospitalization. So the HSCRC, the Health Services Resource Commission, Cost and Resource Commission here in Maryland, collects a bunch of data on who receives services. You can look at in your local area how many people went to the emergency room for opiate use disorder, or what are the demographic characteristics of people that went to the emergency room. Or maybe you were interested in who overdosed, and that could come from local data on overdoses. There's a whole host of data that's available from the HSCRC or from local agencies or from states. Another really important piece of this is partnering. You're not alone in wanting to know what's working and what's not working. And a really important source of information is working with local partner agencies to share data. Local health authorities, local behavioral health agencies in your county or in your region are going to be a valuable source of information. They collect a lot of data on what services are provided and to whom. And they can share that data with you. You can find other agencies doing similar kinds of work. Maybe you work with youth and somebody else works with parents. And so obviously parents and youth are related. And so you can find out, are you guys serving similar clientele, or are there people that are missed by both of your agencies? These are the kinds of data sharing agreements that can be built between agencies that can help you figure out what's going on in your community, that will help you know whether what you're doing is working. And so one of the things that I think is a really an underutilized resource is large population surveys by the CDC or by the census, state and local data that's already collected, widely available on the web. The same thing with national and local hospital data. Hospitals are really interested in working with community providers, and those partnerships can really provide valuable data. And then you have local health authorities that are also doing this kind of work. And so working with these agencies to share data is a really fruitful way to get data without having to collect it yourself. And that can help you answer some of these questions about what happens when people don't come to your service. It can help you answer questions about whether you're targeting the right areas. It can help you answer questions about whether there are groups that are missed in your service delivery. And those things are really visible when you get data from other sources. So when you have your data that you have collected as part of your organization, you filled in the gaps and you have a really clear idea because you have a logic model of whether you're measuring all of the pieces you want to measure, and then you partner this with external data sources, you can have a sense of what's going on in your community. So you have a really clear sense of what you think you're doing, what you're affecting, and you've collected data on all of those elements, and then you marry that to data that exists in your community or with other agencies. And those partnerships can really give you a full view of what's going on. And as Nicole will talk about in a second, in part 2, we'll help you think through how you manage, organize, and analyze that data.
Thanks, Jay. So in conclusion, wrapping up our presentation, what we want to just leave everybody with is first to develop a roadmap using a logic model or using some other visual depiction of the pieces of your program. So the activities, the inputs, the activities, and the longer term, so middle term and longer term outcomes and impact that you're hoping to see from your program. So develop that roadmap, map out what your program is doing, what you expect to change as a result of your program. Think about how you can concretely measure that change, whether or not you have the data to measure the change. So maybe you have some of the data that you need to measure that change, but not all of it. And if not, then look for or design your own measures which capture that change, and then go out and collect that data. And so we're going to leave you here. And in part 2, we're going to pick up with what happens after you collect the data and what you do with it. Thanks. See you soon.
Take care, everyone.